Thank you, Rashmi and John, and the Systemic JA Foundation, and thanks everyone else for coming to this IL-18 Jamboree. This is not a talk. This is just sort of an intro that Rashmi asked me to give to whet your appetites for some manufactured conflict. Some disclosures. And so the title of the talk is really like, is IL-18 testing, is it a game changer? Which is a very fun game show hosted by my good friend Grant Schuller. Or is it a red herring, which if you're not familiar with the figure of speech, it's not just a dried fish. It's basically a false clue. It's a misleading direction, and maybe IL-18 doesn't have actually anything to do with it. And so that is sort of the outline here. And so we're not going to read all of this, but basically I have a case, and then we're going to stop a couple times through it, and maybe I'll pick on people if people don't want to jump in. So this is sort of based loosely on a patient that presented very recently. 6-month-old previously healthy male, full term, no pregnancy or perinatal issues, goes to the ED for some fever and has a non-specific rash and has some low cell counts, hemoglobin of 9. But they call it viral suppression. The kid looks well. They send the kid home. And then 10 days later, the fevers have somewhat abated, but there's a cough, which the parents say is no different than it's been for a while. And still the cell counts are down a bit. Platelets are up from where they were before, but not still normal. But the kid's looking okay, fevers have abated. So then they go ahead and give the child some vaccinations. And, child spikes a fever after that, but looks sort of more sick. They bring back to the ER. This is all mostly true. And now the quite neutropenic and anemic and thrombocytopenic, and the LDH is up, but the uric acid is normal. And so, of course, now finally the child gets admitted, workup for infection, blood cultures are negative. They look for blasts in the peripheral smear. There's a few atypical lymphocytes, but who wouldn't if you're that sick? CRP is not actually that high. There's a little transaminitis, but the bilirubin's normal. Spleen might be a bit big. And finally, they get a ferritin, and it's about 3,500. It's not 30,000, but it's still nothing to sneeze at. Fibrinogen is not super low, but maybe not as high as we might like. And triglycerides elevated. They consult lots of people worried about Kawasaki disease, but none of the other stigmata are there. The echocardiogram's normal. There's no arthritis. There's no uveitis. We drag the ophthalmologist. And one night the child is febrile. The resident turns on the lights and drags, and they see a hive-like rash, which could look like any of these. None of these are the actual child. These are all stolen from Google image search. Based on Google image search, which of these is the Stills rash? I didn't number them, so you can just point. It could be any of them, but this is the one that the internet says is Stills. That is the staminopelic rash, and these are the other diagnoses associated with it. So among the non-specific things in febrile syndromes, rash is not that helpful. So in our institution, we're lucky enough to be able to get a pretty rapid cytokine panel back, and this is what we consider to be a very HLH-y cytokine panel. The interferon gamma is up, the IL-10 is a bit up, and other things are less impressive. Is it specific? No. But it's somewhat reassuring against bacterial infection in some data that are a little shaky, but were recently published you can look at. So viral testing for things that like to trigger viral HLH were all negative. Looking for our functional tests for primary HLH looked normal. We got approval for a rapid whole exome, but that turnaround is going to take 2 weeks. And the child is reasonably stable. So here we are. We have this child who is otherwise sort of fever of unknown origin, has the syndrome of HLH, but we don't know why. And so you want to make this kid feel better. You want to give them steroids. That'll probably help, but you don't know for sure that this child doesn't have something that you wouldn't want to give steroids to, like an occult leukemia, neuroblastoma, cutaneous T-cell lymphoma, all things that we've seen present similar to this. And so ordinarily in the bad old days when we weren't paying as close attention to Dr. Shimizu's work, maybe because he must have been only 15 when he published the first paper. That's a joke because he looks much younger than me. We would do a bone marrow biopsy and we'd probably do a pan CT scan. And these things have risks, even if our pretest probability for this patient having malignancy is pretty low. So what do we do? And then enter IL-18, where we could finally say, I don't need those other diagnostic tests. If it's in the range that Dr. Shimizu has talked about, 20 to 40,000, depending on where you're measuring it and what other things the kid has going on, you might be confident enough to say this is either Still's or one of our monogenic IL-18opathies. We'll wait for the genetics, but we can start treatment. And if it's not that high, it's still useful because you can kind of rule that out and feel better about exposing the child to those more risky things. So, fine, it's Still's. I swear I'm done. Let's say that this child has an IL-18 of 128,000. That's pretty high. I think that's above any threshold that has been thrown out. The CXCL9 is about 14,000, consistent with the MAS HLH-ness of this kid. Soluble IL-2 receptor, high, but maybe not that high compared to what you might see in a primary HLH patient. And so, you're going to give anakinra, maybe, depending where you are. Start some steroids, we certainly would. And let's say the patient has a good initial response. And so, we're going to do a show of hands. We should recheck an IL-18. Should we check it in an hour? Raise your hand. Okay, so we can agree that hourly IL-18s are not useful. How about in a week? No one would recheck an IL-18 in a week. Out of my mind. How about in 2 weeks? In a month? Okay. How about as needed maybe? How about never again? We've got all the information we ever want from an IL-18. Come on. Somebody? The red herring team? Nothing? Okay, the right answer is hourly. So let's say that our young patient, we're trying to wean glucocorticoids, but just can't seem to get them down. The ferritin, the fever, the LFTs, they sort of bump. You're sort of what this place that I like to call smoldering MAS, but maybe not quite meeting criteria. You've bumped up the anakinumab dose. Who would recheck an IL-18 at this point? Is it at all valuable? Okay, I've been told we're not going to go with the usual suspects. So, young lady here, please tell us your name. What's your name? Rita. Can someone give Greta a mic? So, Dr. Connolly has one. So, Greta, please tell us, why would you order an IL-18 now? What would you do with it? You don't have to, these are things I wrote. They're probably not right. Okay, so if it were high or not high, how would you think about the patient differently? What kind of a level would be reassuring or exciting to you?
I would just like understand the disease activity is still very high, and so I'm not in the right direction. So I have to change my biological or my treatment in another direction.
Okay, awesome. Thank you for sharing. All right, who else wants to talk? We're supposed to make this. I believe Fabrizio might have had his hand up first.
No, I would have rechecked IL-18. This is for
so
sure.
Why?
Because I think you're not controlling the disease, and you want to know whether you are in that IL-18 high subset of, Stills or SJA, whatever you want to call it. And this IL-18 high subset would certainly, represent a high risk for lung disease, potentially for relapsing MAS, and I think that's important. Which cutoff, I have no clue, but high.
So I think Grant wants to play devil's advocate. Is that right? Yeah. Oh, I would love to see this.
I mean, I'm always interested in the numbers, right? But I don't know how it would change my approach. We know the child isn't doing well in therapy. We know they have clinical risk factors for things like lung disease based on the age of presentation, the lack of arthritis. the fact that they're not responding to initial therapy. So it's going to be high, but if I don't know what I would do differently if it was 20,000 or if it was 150,000.
So is there anybody here who would, we'll go through these. At this point, is there anybody here who would make a decision about whether or not to do like a CT scan or other screening for lung disease based on the IL-18?
Well, I would like to know what's the baseline. I would like to start with a baseline level of IL-18 in this particular case, and then recheck the level at this stage and to see what the trajectory
But
is.
you don't have a baseline. You have the
We
one
do.
we
In
started
Cincinnati,
with.
we always do.
Well, no, you didn't raise your hand when I said who wants another one in a month. So you only get the one at diagnosis. It was 128,000 at diagnosis, and here you are, however many months later.
So that's a question. Exactly. So I would like to look at the long-term trajectory. And I think the long-term trajectory will tell me how much I need to worry about the complications. I very much liked your slide, Professor Shimuzu, showing those long-time trajectories depending on the course of the disease. I think rechecking the level, see what the trajectory is. Are we going down, stable, up? Will predict complications. So I think it's not the number, it's the trajectory.
Dr. Marquez. Talk to each other. I don't want to be the focus.
It's a silly question, but the patient started a disease onset of 6 months. Has anyone seen a patient that started at 6 months that actually just was a monophasic and did well? You have, Dr.
It wasn't this one. Well, actually, I hope it's this. This is relatively new.
Can I frame the question to the parents here? I know some of you ask your doctors for getting the IL-18 levels. Would you like to speak up as to why you do that? Honey? Sorry to put you on the spot.
So what is the question? Sorry.
Can you share some of your ideas or challenges in getting IL-18 tested, period?
Well, challenges is that a lot of places don't right off the bat do that. And I mean, you'll hear our story a little later, but we pushed our initial rheumatologist to get us IL-18s, and we pushed twice and was rejected. And that caused us to move for care, essentially. But yeah, so I mean, in this case, I would definitely push to get the IL-18s checked again because I would want to know if my child is responding to the medication or if we need to change it or do something different.
Is Dr. Henderson online? Because, or maybe is Dr. Walma here? She's in the chat. So somebody published this is how we screen for lung disease,
Yeah,
right?
Scott.
Zero
Dr.
data, but they published it. So, you know, does IL-18 factor into that at all?
Yeah, so Dr. Henderson said we screen patients for ILD if they have very high IL-18 ever.
All of them, even if they, like, you give them a drop of anakinra and they never have disease again?
Dr. Henderson, you have to answer.
Yes!
Yes.
Ladies and gentlemen, Lauren Henderson.
We would send to pulmonary and not necessarily get a chest CT, but we would send to pulmonary just because, you know, many of the publications have shown that high IL-18 is associated with lung disease, and they might do a chest X-ray or a walk test, a pulmonary function test to start. If those are abnormal, we might proceed to a chest CT.
So who would have had this child screened for lung disease before we ever got to this point? Show of hands.
With or without animals?
No, when we were here, oh geez, when we were here, good response to anakinra, who would have said, based on what you have here with this IL-18, or even without it, because you kind of know what the kid has, who would have sent the kid for lung disease screening at that point? I don't know. I'm going to invite Dr. Wabma to talk. What do we mean by screening in a 6-month-old? So it won't be a walk test. It's not going to be PFTs, obviously.
Formal PFTs as like the go-to for like initial pulmonary screening. I don't think with our algorithm, we were suggesting everybody should be exposed to chest CT or the cost of a chest CT, but at least looping them in to pulmonary medicine because catching something early seems more ideal than kind of catching up later. So that was our perspective, and Dr. Henderson, you can expand upon that if you'd like.
All right, I'm being told this side of the room, is that Dr. Brogan?
I broke my own rule. I've got a rule that says never make comments when you've been traveling for 20 hours. But here goes. Yeah, it's irrelevant, the IL-18. You're going to do a CT of the chest in this child. This is less than 6 months. I completely agree with the comment. None of them do well. Biggest risk factors are mass, under the age of 2 years, and sick. And clearly this is one of them. So you can measure IL-18 hourly, and we can do it, and you get the result in 3 months. So you're always retrospective in some institutions, even who have an interest in this. But you don't need an IL-18 level to know if your patient is doing well or not.
Anyone disagree with that? Wow, you're...
Coming back to trajectories, you know, I'm following quite a few patients over time, and I'm seeing a sudden increase in the levels of IL-18 with sort of otherwise relatively stable picture. To me, that's a trigger for an additional screening for lung disease. The other thing about your patient is that I think you mentioned some urticarial rash at the very beginning, correct?
There was some rash.
Well, the very first slide, it was the resident sort of
Yeah.
told you that it was urticaria. That's another sort of kind of the pruritic rash that occurs in a child with very high levels of IL-18. To me, it's a red flag.
All right, so we can always circle back. Okay, so let's say now, so in our institution, what would we do? We don't screen everybody, but if you're still like needing medicine after a month or so, you're gonna get a CT scan at this age. And then we may or may not send it for, you know, I don't know that we have a great policy in terms of changing therapy prognosis, but that's what we do, let's make it right. So we would put this child on ruxolitinib. We really liked ruxolitinib for these kids. And let's say that our child does great. We would certainly probably get them on higher doses than this, but let's say you've weaned down a little bit and you're at this sort of happy, steady remission on medication, however you want to define it, with normal labs on these meds, let's say for 18 months. And so, you know, the parents are like, well, that used to be scary, but now we want to stop dealing with all these meds. So what are the right minimal residual disease markers? And I failed to put, there's an actual, somewhat of a study in stills of, I believe it was calprotectin, S100, A8, A9, that if your level was above X on, you know, remission on medication, you know, you were more likely to flare, and if it was below a threshold, you were less likely to flare. So there's at least some data to support S100 levels. I know there's accumulating data, thanks to Boss, for other things. So who has thoughts about how are you reassured about stopping meds in this patient?
Yeah, sorry, I have a question for you. I mean, you have missed the commonly used CRP in the list of
normal.
MRT biomarkers, any deliberate, is it done deliberately or what's your thought on that?
The CRP is normal.
CRP is normal. How is the child?
I'm sorry?
How is the child?
Great.
Then why to
How
bother?
old? I don't know. We haven't gotten there with this one. Let's say 3, 4. It's been a couple of years.
Yeah, I mean, if the child is doing fine and if the CRPs are normal, then why to venture into this area?
Ooh. I mean, I'll take that bait, but I'll let someone else. So he said, why venture into this area?
I mean,
It
if
looks
the
good.
child is clinically stable, and
Yeah.
as Paul told that there is no recurrent mass, the mass is settled, the child is doing clinically well, the ferritins and the CRP and the counts, which are, I mean, available on table for most of us in routine clinical practice, if these things are normal, and so do we really need to go for IL-18 or the other stuff that you have seen as a tool for monitoring the disease?
That is the question. So you might vote for none of the above. You have the information you want. You're ready to start weaning medicines. Anybody else who is happy with the information they have? Dr. Bello is not happy or wants to talk, or both.
I always want to talk.
They would love a mic.
No, I don't need a mic.
Well, the online folks might.
All right, I'll have to turn it down a little bit then with the mic here. I mean, you said, what do you do, right? My opinion is that if they're normalizing all of these values, in my lab, we don't check the S100 proteins because they're not available, but we do check the IL-18. And if I see a patient in clinical remission on medication and the IL-18 doesn't return to normal and remains elevated, I personally take pause at that point because, as you know, my hypothesis and bias is that I think there's genetic variants that are driving this phenotype, and I think the elevated IL-18 is part of a genetically driven phenotype.
There's no genetic basis for
No.
IL-18 elevation.
Yeah, exactly.
That's sarcasm.
And so in the end, if the IL-18 doesn't return to normal on therapy, I at least take pause about the possibility of stopping therapy in a child who's in clinical remission otherwise.
Okay, I mean, that is a very defensible position. So Dr. Bello would say, I don't care what CRP, ferritin, CBCs look like. I don't care if he's 25. If his IL-18 is still, how high?
It was an assumption that those others were already normal.
No. These are what you have to choose. We don't have any of these yet. So you would get an IL-18. You don't think 6L9.
I would get a ferritin, I would get a C-reactive protein, and I would get an IL-18.
Okay.
If they had a high LDH in the past, I would get an LDH as well, but if the LDH wasn't elevated, I wouldn't necessarily.
So not a lot of love for the S100 proteins. I think like Dirk Full's gonna burst through the door and rip this shirt.
No, we do the S100.
So do you think that's a better minimal residual disease activity marker than 18, than 6L9, than ferritin?
No, it's available in our hospital, so we do it locally. It's also hard to get the IL-18. We get it after 2 or 3 weeks, so we have to send it out, and it's a very good marker, I think. It's very sensitive. If you spin it down right away and measure it, you have the results in the next day. So I think it's very worthwhile if you have the decision to reduce ruxolitinib or canakinumab. So I would do this definitely at that point.
I think Dr. Dodioglu had her hand up first, and then we'll go to Dr. Grum and then Dr. Denver. Yeah.
So, yeah, Fatima is fine. So I think by that time you would know, like as Alexei said, that you would have some trajectory about the patient. You know the inflammation, how it behaves in that patient. You know how the trajectory was. So then I would do definitely the ferritin D dimer, fibrinogen, and IL-18, and decide if sometimes even when IL-18 is a little high, I start weaning. Because I know the trajectory of that patient, how it behaves with infections or things like that. That's why.
I think these gentlemen had something to say. I'm out of slides. That's my last one, so we can.
I think you should your neck out. Mike, say a number. Just give a number.
The number in my mind is around 800, but I have a patient who had 350, and I counseled that I was concerned about them as well.
So, I mean, the one counterpoint to that is we've followed patients. Now, we happen to know they have certain, like, obvious mutations who are in their 60s, and their IL-18s have never been below 40,000. Every day of their life, not that we've measured it every day, but, you know, and so, you know, and like, are we going to keep them on Ruxo or Alaris or, you know, both?
I'm following a good number of patients with systemic JIA, and a good proportion of them are doing well.
Probably, I observed a complete normalization of the levels of IL-18, maybe just in a couple of them. So the vast majority of my patients, even those who are doing well, still have elevated levels of IL-18. My personal rule that doesn't have any scientific data to back it up, but my personal rule, if the levels is hovering somewhere between 2,000 and 3,000, I'm comfortable tapering the treatment. And I have done it successfully in quite a few patients who still, even without medication, still show elevated levels of IL-18. So the point is that I think a complete normalization of IL-18 in this patient population is extremely rare. Boss would not agree with me, but that's what we see now.
Here, I can settle. So, I mean, one of the elephants in the room that I'm going to give is we're all talking about like numbers of IL-18, but we're not running them all in the same labs. And as was recognized recently, like if you're running it in my lab, you get the best recovery, but otherwise it could really be quite rare.
I think that's a really important point, Scott. So what we really need, and that's what Grant and Christoph Kessel now are doing, is that we are comparing the cutoffs for inactive disease or elevated levels. And those are probably really different in the different labs. So we've been measuring in the past 5 years all of the new patients in the Netherlands in the 6 academic hospitals in the first 2 years. And I will show the data on Friday morning, but we see a majority of patients that respond well also have complete normalization of IL-18 levels, at least in the Netherlands, but not all of them. So we also have around 30% of patients with persistently elevated IL-18 levels, and you can see that even already in the first 3 months, the trajectory.
Do we have some questions from Zoom? Maybe?
So the question on Zoom was really more of a comment, which was a patient who kind of had this experience, although probably was a bit older, of remission on medication, and everything else looked normal, and they started to wean and then had a flare. And I believe that was a patient who the 18 levels really hadn't normalized very much. And so, I mean, you know, I think that like what we're building at here is that IL-18 itself is not sufficient to drive whatever we're going to call the syndrome of Stills/MAS, but at that it's sort of a risk factor. I have had a couple of patients who did normalize their 18s and then flared a couple months later, in one case like a year plus later, and the IL-18 was back up to 80,000. So, you know, I think that we all want to have these sort of confidence in minimal residual disease activity markers, but, you know, I think that susceptibility, and nothing's perfect. Has anyone else had that experience? Maybe I'm just confusing people.
It's Mona Ruscella. I was just going to say I had that same experience, and I want to make sure that we're not giving people false hope that if the IL-18 is completely normal, that we're not going to see their kids flare, because I had the same experience recently.
But I mean,
a very mild case, right? And the IL-18 was normal.
Yeah.
So,
Do we leave them on therapy into their 40s?
no, I'm just saying that if it is normal, I mean, I think, you know, whether that means we feel more comfortable weaning them off, I think that may be appropriate. But to give people false hope that, oh, that means you're not going to flare in the near future. Well, 9 months later, you know, it happens. But I agree with Alexi, just the trending of it, I think, has been really valuable for me personally.
I had a question for Dr. Lee, actually. I'm curious if you're measuring IL-18 in China at your hospital. No?
What?
No.
Can we shame Feng
different,
Shao
I think
right
it's
now?
different situation. We don't check. We just the ferritin over the ferret, because some cytokine is very expensive. So not for everybody check the cytokines. And also, for the people, we just check the CBC and like a CRP, and the clinical manifestation is very important. We check if the patient very active in 1 month, and if the patient just stable maybe 2 or 3 months, and we don't check so details. We don't have so much money to check that. For it's just depend the patient and the parents and also the physician assessment. Thank you.
Yeah, I mean, access is a big problem. We're very lucky in the US at least that we can now send an IL-18 level and get the result back in 24 hours on business day. We've never actually done that, but and across state lines is not a problem. I'd be interested to hear from our colleagues in Europe and maybe in the UK, sort of one system. But if you're in Liechtenstein and you want to send an IL-18 level, can you send it to Rome? Can you send it to Germany? Like, what are the rules around that? I mean, I don't know if we have anyone from Liechtenstein. As a clinical test, or does that have to be sent as research, or how does that work?
No, Bas, I think you can reply better than me, but you can, of course. For example, I work in Milan, and we don't perform IL-18. We send it to Rome. We are lucky because we are in the same country, of course, but it depends on shipping rule and of course, agreement between institution, but it's quite easy to do it.
For free? Well, I mean, is that because the Pope, does the Pope pay for it, or?
Scott, another question. All the clinical labs that do IL-18, at least in the States, they all utilize commercially available kits. There are not that many. So what do we know about what kits,
So, I mean, I can say that in Cincinnati, you all use the Ella platform. That's what I believe y'all in Rome are using.
We can use the other platform, the R&D.
Oh, okay, the Duo set. There's someone online. So I can summarize. In Rome, they can use the sort of old-fashioned Duo set, or they can use the Ella platform. My lab doesn't do this clinically, so it doesn't really matter. The Mayo Clinic runs it on a plasma cytokine Luminex panel that doesn't work. They will not report out over, I think, 11 or 12,000, which didn't happen until we emailed them and said, your assay is wrong, you're missing a whole bunch of things. So how you measure it, it's not hard to measure, at least in our experience, that the antibodies are quite good. You just have to dilute the sample appropriately, or you'll hit a pretty classic hook effect. But I think to your point, and something that the Systemic J Foundation is working on is, is there any commercial push to make a test that could be then sold to small hospitals as a clinical test?
look at the Japanese data. They come up with beautiful receiver-operated curves and you define the cutoff levels very nicely. What about, can we use those cutoff levels using our assays? I'm not sure. So I think there is quite a bit of room for.
Yeah, it is something that we've been trying to find any company that is interested in developing a test in this space. And if we've actually found one German company but it's focused on S100. But we are interested in seeing if we can help any company kind of understand the market and maybe develop a IL-18 test that can be ordered. I've been asked to try to wrap this up soon, so maybe like one more question, or do you want to go for a bit? I think Mariana had some.
Sorry, I feel bad now that this is the last question, but it's
because we talked about like normalizing IL-18, but again, similarly to the question of has anyone seen a 6-month-old that did well? Has anyone seen a patient who had an IL-18 of 50,000 and never below 50,000 that did well and you took off the therapy? And we've seen some that everything else looks normal, but they still have an IL-18 of 50,000. Has anyone seen one of those patients do well once you taper them off therapy?
So Fatma raised her hand. I mean, I'll say that like these same NLRC4 patients that we followed, like the initial description was, you know, the index patient was actually an infant who died in infancy. And, you know, the stress of that plus an infection, his father ended up in the ICU, but had never known that he had anything except that he was one of the people in the first case series of TPN given to infants, but kind of grew out of it. So, yeah, Mike's face was classic there. So, yeah, I mean, past this prologue. So there can be long stretches of normal life off medicine for some of these folks.
I just want to emphasize that you definitely need to continue to watch the patient, and at any point you have to, like, that patient that I remember had an MAS flare at some point 5 years later. Then the IL-18 went up to 300,000 from 40,000. So.
We haven't heard one mention of IL-18 binding protein. So are the patients who have got massive total IL-18, are you just measuring neutralized IL-18 because they've compensated, they've got IL-18 BP? So we really need to not focus on just one cytokine. We need to focus on the totality. The cytokine system is chaotic. There's so many things going on. So I think we need to just remember.
I think that's a good point. I will say that unlike IL-18, measuring binding protein, the reagents are not as great, which is why it's not been clinically offered, I think, consistently. And the reagents are not great exactly when you need them. And so basically, the higher your IL-18 is, the more inaccurate your IL-18 binding protein measurement will be. So it makes it a little bit tough. And so what we kind of do is sort of, we say, okay, IL-18 binding protein is induced by interferon gamma, which also induces other stuff like CXCL9 or soluble IL-2. And so we say, if your IL-18 is really high and those interferon gamma biomarkers are maybe not so high, then there's probably a lot of unopposed. Whereas we've definitely had, especially some like inflamed cancer patients who've had total IL-18s in the 40,000 range, but their CXCL9s and soluble IL-2s have been in the bajillions. But they were not such diagnostic challenges. Has anyone been burnt by a high IL-18 and diagnostically it sort of sent you down the wrong path? If you think it's MAS and the IL-18 is not 60,000 or 40,000 plus, is it not MAS? Is it something else?
As any way to measure IL-18 in MAS driven by T-cell lymphoma?
Yes, and T-cell lymphoma, I mean, I can think of 3, and those are actually the ones that were quite high. The total IL-18s were 20 to 30,000, but the other HLH biomarkers were among the highest we've ever seen. These were all adults as well, and so it was sort of that dichotomy of the HLH biomarkers being so incredibly high and the IL-18 being higher than we see typically, but not. You know, if you're looking at that person and we do a lot of guessing of like, what's the IL-18 going to be? Because it gets boring in Philadelphia. So, you know, that's someone you might have guessed it was going to be 400,000 and it comes back 20,000. But I agree that that's sort of the ones that keep us up is especially the cancer patients. And I think if adults start measuring this a lot, I think that they're probably going to be some blind allies.
Any last comments? And then we'll wrap up for the evening. Okay.
Was that okay? Was there enough conflict?
I think we have
Fatima
a
wants more
last-
contact.
yes.
I mean, there are like some hyperinflammatory patients that fulfill criteria for MAS, but they don't have a lot of IL-18 higher, and they don't have cancer, they don't have anything else, and they had, like I have a few patients, like college students and high school, I found vitamin C deficiencies in them. I'm not saying that's the cause, but like it's just, it's interesting that they had this hyperinflammatory process. And some was able to stop their medications in a year or so, some needs longer. And I still don't know. So they, yeah.
Okay,
Very
thank
good.
you so much, Scott.
Thank you.
Thank you for, I'm
And thank
glad you
Dr.
made it.
Shimizu for getting this all started.